from ecological problems. Gee, who would have thought if we dumped toxins into the ocean and into the air that would be a problem one day? The kinds of short-sightedness, the fact that people make decisions according to criteria that really don't work if what they want is to pursue a quality of life. So with that kind of an introduction, let me orient you to the different aspects of what I intend to talk about over the course of the next hour. My talk is divided into 5 distinct sections, and I'll spend probably an average of roughly 10 minutes on each section, acquainting you with the key ideas and hopefully translating that into, so here's what it means to improve therapeutic efficacy, since therapeutic efficacy is the name of the game. We're always wanting to do what serves our clients best. Section 1, I'm going to identify some of the specific patterns, obviously not all of them, for how therapists differ in the way that they think about their clients' problems and the way that they think about hypnosis as an intervention. Section 2, I'm going to show you a case example. I'm going to show you a clip that's roughly 3 minutes long of an interview with a woman I've never met before, that she's an attendee at a conference. She volunteers to be my demonstration partner. But in the span of 3 minutes, you should be able to see exactly what I'm talking about when I start talking about what are termed discrimination criteria. Now, I'll introduce that term and define it for you, obviously, in that section. Section 3, I'm going to talk about discrimination strategies and quality of life, how you determine which path you're going to follow. Section 4, I'm going to focus on process-oriented hypnosis. What I've been particularly interested in all along, for at least now the last 20 years, has been the issue that is most bothersome to me. I've been told that at this point, there are more than 800 different distinct forms of psychotherapy on the books. Do we really need 800 different forms of therapy? But it tells you how internally divided the therapy field is. And how many different models of hypnosis are there? Hypnosis is also an internally divided field. People who have very different viewpoints about the nature of hypnosis, the nature of hypnotic phenomena, how you should use it, when you should use it, with whom you should use it, and likewise with whom you shouldn't, and all these different perspectives that people have. And the problem is a pretty apparent one if you think about it. How much of the therapeutic process revolves around projection? And I mean projection by the therapist. That the client presents a problem and one therapist interprets it this way and another therapist says, no, you're wrong, this is what's going on. Another therapist says, you're both wrong. And then the next therapist says, I could agree with all of you, but then we'd all be wrong. And you run into that same kind of issue that therapists interpret people's problems, and then like their clients, they make the mistake of believing themselves. So it's really been kind of a mission of mine. How do we reduce the amount of interpretation in the therapeutic process? How do we make it easier and more efficient to identify the patterns that regulate the person's experience with a minimal amount of interpretation? So that's what I'm going to introduce by way of process-oriented hypnosis. And then in the very last section, I want to share with you a most unique project that I got pulled into some years ago that takes my therapy skills and applies them in a totally different environment, different than anything I've ever been exposed to, and it was fascinating, and I want to share that with you. So let's get rolling. Section 1, how therapists differ. Every therapy, you can list all 800 therapies and you can summarize in a sentence what that therapy focuses on. Whether this therapy focuses on emotion, whether it focuses on cognition, whether it focuses on history, whether it focuses on imagination, whether it focuses on what. Every therapy has a focus. So the question is, what is the focus? That when somebody introduces a problem to you, where do you automatically go with it? How reflexive is your therapy? How dedicated are you to a particular therapeutic modality? When somebody says to me, well, I'm an XYZ therapist, whatever the XYZ happens to be, my first thought is, that's a shame. Here's all the things that you're never going to be able to do from that perspective. To be loyal to a particular theory is very different than being able to respond to the patterns that people use to regulate their subjective experience. So, do we focus on skills? Do we focus on motivation? Throughout the whole history of therapy, people have been analyzing people's motives. That if somebody has a problem, it's because they're afraid to deal with it, and so it persists, or the problem serves a purpose. People get taught the notion of secondary gain as if it's a fact of life. In my judgment, secondary gain has set the field back 25 years to automatically assume that there's a payoff for it. And then people actually ask that. Everything has a consequence. It's a big jump to think that the consequence necessarily drives the behavior. Maybe it does, maybe it doesn't. It requires another discrimination. But motivation isn't enough. Nowhere in my writings, nowhere in my teachings are you going to see me talking about somebody's unconscious fear of success or someone's unconscious fear of failure. It's just not concepts that I think of as being useful, as if the person was properly motivated, then magically they'd have the skills. Motivation's not enough. It doesn't matter how intensely motivated you are to watch the sunset, you face east and you ain't gonna see it. There has to be an ability as well. And we want both sides to be addressed. How much skill, how much motivation is going to help this person get where they need to go. Temporal orientation, I see that featured heavily at this conference. Temporal orientation refers to whether your therapeutic approach is more oriented to the past or to the present or to the future. So many therapies that focus intensely on the past, and the person's using the past as their reference point because it's all they've got. Milton Erickson was absolutely right in my judgment when he said, people don't come to therapy to change the past. They come to change the future. I believe that wholeheartedly. The evidence-based versus the subjective. People who are notoriously adept at ignoring data, who don't feel like they need to read the research, don't feel like they need to know the science because they're happy just with what they're doing. And the problem, of course, is therapy as a subjective process. So often what we're working with are people who are anxious, people who are depressed, the two largest, most common, most prevalent problems that we as therapists are asked to treat. The problem is that these are disorders that are highly responsive to placebos, which means you can do almost anything and the client's going to tell you they feel better. Stand on your head for 15 minutes while you're singing the national anthem. They'll say, wow, that was really an important experience for me. Problem-focused versus solution-focused. Pathology-based versus strength-based. I got into a discussion earlier where we're talking about the views of hypnosis as there are certain diagnostic categories you shouldn't treat. You shouldn't treat depressed people with hypnosis because they're going to commit suicide. You shouldn't treat psychotic people. You shouldn't treat borderline people. You shouldn't treat... I have to remind everybody, you don't treat diagnostic categories, you treat people. And every person has a history, and every person has strengths, and every person has vulnerabilities. And what's the purpose of therapy then, if not to connect people to those strengths and to think in those terms? And likewise, intrapersonal versus interpersonal. This is probably the biggest change that's taken place in the field of hypnosis in the last 20 years, and it hasn't reached everywhere yet. But people who view hypnosis strictly through a lens of intrapersonal, that hypnosis resides within the person. Whether they're hypnotizable or not, let's administer a suggestibility test or a susceptibility test. But that's a very different point of view than to view hypnosis as an interpersonal phenomenon, an interpersonal process, something that exists between people. Why this person gets better results than that person. They're better at the interpersonal side of the equation. And they understand how that quality relationship is everything. The very first lesson you learn when you study hypnosis, presumably, is that what you focus on, you amplify. And so now what I'm doing is raising the question of, what do you choose to focus on? What do you want to amplify and why? And without a plausible rationale, without a really informed rationale, it's just too easy to go into doing automatically whatever you do. Or even more difficult, people who can't tailor their approach to the individual because they're reading scripts to the person. Scripts can be useful in prompting you, giving you ideas, giving you imagery, and so forth. But the fact that there are 10 different smokers who come to see you and all 10 hear the same script just because they happen to share a bad habit, and yet they're entirely different people, very different backgrounds, different values, different experiences, different hopes, different everything. Well, let me show you what I'm talking about more directly. This is a 3-minute video clip, and it illustrates my point that here's a woman who volunteers, who has been dealing with this very tough issue her entire life. And literally in the span of 3 minutes, I can pare it down to, here's what you're missing. Part of the way that I think about the nature of therapy is people are socialized. And in the socialization process, they learn certain things. They learn that this kind of behavior gets rewarded and this kind of behavior gets punished and this kind of focus is okay and that kind of focus isn't. And they go through life learning these things. But it's what you don't learn that comes back at you. I don't know if you've ever seen the video on YouTube called The Invisible Gorilla. If you haven't seen it, go to YouTube and type in the search engine, The Invisible Gorilla. It is a perfect metaphor for what I'm talking about. The experimenters had people in a circle, 3 people in black shirts, 3 people in white shirts, and they were given the task of passing a basketball back and forth, and the research subject's task was to count how many times the people in the white shirts were passing the basketball back and forth. So while they're busy counting, because the ball is moving pretty quickly, a guy in a gorilla suit slowly saunters into the middle of the group, beats his chest, turns around and walks out. More than half the research subjects reported that they never saw the gorilla. They were so focused on the white shirts. And to me, that's a great metaphor for how we move through life. Our parents, the other significant people in our life, turn our attention to this and we miss this. Nobody ever sat this woman down and said to her, kid, here's what you need to know. And as a result, here's how she presents her problem. What would you like help with?
I have trouble kind of trusting other people to be there for me. I tend to be really independent. Have a hard time asking for help, even from family members.
A hard time trusting that people will be there for you.
Correct.
How do you know who should be trusted to be there for you?
Well, I think like my husband I should trust, my adult children, it's kind of my siblings, and even my work colleagues.
Okay, now you've told me who you think you should trust. The question I asked was, how do you know who you should trust?
I think because I trust them, or I think they trust me, that it's reciprocal.
If somebody trusts you, that means they're trustworthy?
It doesn't make sense, does it? I guess I don't have a good answer. I don't know.
Okay. So even as you hear yourself say that, what occurs to you?
It's a probably intellectual kind of thinking about it versus maybe not feeling the trust or understanding it.
So this is what confusion looks like. She starts by saying, I don't feel like I can trust. Problems with trust. I ask a how question, a discrimination question. How do you know who you can trust? She basically says, well, I guess if I know them, I should trust them. I should trust my husband, I should trust my brother, I should trust my sister, I should trust my colleagues. How many of you have relatives you wouldn't trust as far as you can throw them? But what that reveals and what you push your client to say is, I don't know. That's the goal of the interaction, to get her to acknowledge, here's this piece of information missing, what I call the experiential deficit. She does not have criteria for determining who's trustworthy and who isn't. Consequently, she has trusted people who shouldn't be trusted and obviously been betrayed by them, which is why she has the issues. Now, if this was your client, where do you go with it? Look at the different options here. Are you going to hypnotize her to find the root cause of her problem? Are you going to address her dichotomous thinking? You can either trust them or you can't. Or her unrealistic expectations that if you're married to this person, or if this person's a relative, you should be able to trust them. How unrealistic is that? Help her explore her feelings. Let's talk about all the hurt you've experienced from the betrayals that you've experienced in your lifetime. Emotional ventilation for the issues. Explore her attachment history. Get her into couples and family therapy. Well, what are we going to do with this lady? And therapists would go in a million different directions with her. And what I want to do is bring it back in, because you saw with one question, how do you know who you should trust? What's called a discrimination question. Every discrimination question starts with how. How do you know whether it's this or whether it's that? And when the person's answer is, I don't, that's the point. That's when we use hypnosis and any other therapy tool we have available to help this person develop realistic criteria. Now, if this was me and you were my therapist and I asked you directly, so therapist, how should I know whether to trust someone or not? I'd love to hear your answer. Because if you don't know how to answer that clearly and succinctly, you can't teach people what you don't know. And therein lies the problem. The therapists go into domains that they're comfortable with because this is just what they do, but isn't necessarily what the person needs. Exploring her attachment history, it will explain why she never developed discrimination criteria. Bringing in her husband to explain why he betrayed her isn't going to help her be any more knowledgeable about who to trust. She needs to be guided through a sequence that helps her identify, here's how I know. Here are the things that I need to assess. And when you look at how difficult relationships are for so many people these days, you know, they get into these relationships, and when I ask them a question like, how did you assess this person when you met them? And they look at me blankly and say, assess? Well, yeah, how did you determine whether or not this person was going to be a good fit for you? Well, what are you getting at? The question defies their understanding. And that's the point, is the interview can be relatively short to get to that point where the person is able to say, I don't know. Here's what I'm trying to do. I'm trying to have a good relationship, or I'm trying to have a better business sense, or I'm trying to have a better set of friends, or I'm trying to, whatever it is. How do you make those decisions? And when the person has a strategy that is clearly not working, not gonna work, you'll see the kinds of problems that they're gonna have as a result. Well, let's talk more directly then about discrimination strategies. When I talk about discrimination strategies, what I am referring to are the kinds of criteria, the checklist, if you will, of here's how you know whether it's this or whether it's that we want to go after. At this point in my career, half a century into it, I would venture to say that truly 99% of people's problems are ultimately discrimination problems. They just don't know what the salient focal point is for what they're trying to do. So you ask somebody, well, how did you make this? This is particularly true when I'm dealing with depressed people. How did you make this decision? Well, I followed my feelings. There are therapists running around loose in the world who tell their clients, trust your feelings. Why would you tell them that? Can your feelings tell you the truth? Yes. Can your feelings lie to you? Yes. Discrimination. How do you know when you can listen to them? How do you know when you need to override them? But it can't be a reflexive, I just follow my heart. I just listen to my gut. Your guts can lie. How many of you haven't fallen in love with the wrong person? Feelings aren't hard to manipulate. Hollywood does it all the time. Throw in a little piano music in the background and everybody gets all sad. It's just how it is. So it's these discrimination strategies that I'm going to focus on for the next few minutes. At any given moment in time, almost any given moment in time, you have at least two options available to you. Am I going to do this? Am I going to do that? Am I going to respond to this? Am I going to ignore it? Am I going to say something about it, or am I going to walk away? Am I going to get involved in this, or am I going to stay out of it? Constantly having to make these kinds of decisions. Let's look at where these discriminations show up in the course of everyday living. See, here's the phenomenon that has been so interesting to me. There are many different models of depression. And being somebody who has more than a casual interest in depression, I'm very familiar with these models. And there's one model in particular that is a relatively recently developed model, now probably about a dozen years, that has garnered an amazing amount of empirical support already, and it just keeps expanding. It's a model called the stress generation model of depression. And the stress generation model speaks to how people who are depressed or people who are vulnerable to depression make bad decisions that exacerbate their depression. What does that look like? I'm a depressed man. My wife says to me, honey, I'm worried about you. Won't you please go see the doctor? And I say, leave me alone. And of course, my depression persists and gets a little worse. And she comes back to me a couple weeks later and say, look, I hate seeing you like this. You need help. I don't know what to say. I don't know what to do, but you're crashing and burning. And I say a little louder, leave me alone. And more time goes by, and my kids don't want to see me. My friends have stopped dropping by, and I can barely get out of bed. I look bad. I feel bad. I smell bad. She comes to me and she says, that's it. I'm not living this way anymore. You either go get help or I'm out of here. And I go, whoa, really? You would do that? Yes, I would. Fine, I'll go see a therapist. And I end up in your office. Your magazines are outdated, by the way. So, all right, you pull me into your office and you start asking me questions, and you ask me about the history of my symptoms, and you ask me about my family history and my occupational history and my social history and the history of my history. And then an hour later you say, okay, so you're depressed. And I say, really? Who would have guessed? So, okay, we're spinning wheels here of not really going anywhere. So on the way out, you say, I think I can help you. If you're a doctor or psychiatrist, you might say, here's a prescription for an antidepressant. As I leave the office, I don't schedule another appointment. I throw the prescription in the garbage can. bad decision. Bad decision. And that's how people make decisions according to what they feel. That's particularly true amongst depressed and anxious people. It's true for us, all of us in general, but especially true. It's what's called, in clinical terms, the internal orientation. The person responds to their feelings, their ideas, their perspectives that may have next to nothing to do with what's really going on out there, but they're responding to themselves. If you want to know why cognitive therapy ends up working reasonably well for most people, it's because it's so great at teaching people to get out of themselves, develop an external orientation, and do some reality testing. Let's find out if that's what's really going on. Here's what you think is going on. Let's see. All right, so the places that you make life quality decisions. Is this love or is it lust? What happens when you can't tell the difference? Am I ready for a new relationship now or not yet? Should we or shouldn't we have kids? Is there any bigger decision? You know, the biggest decision in life that shapes your quality of life is who you partner up with. But right behind it, 1B to 1A is, should we have kids? Huge factor in shaping quality of life. And people who are so cavalier about it, they've never thought about it. You get married, you have kids, or you have a relationship and you have kids. And there you are doing therapy with people, listening to their stories about all the stuff they endured, and then you're wondering, why did this person's parents have kids? They didn't have the temperament for it. They didn't have the knowledge base for it. They didn't have the character for it. It's a decision with enormous consequences. Better to live here or somewhere else, better to eat this or that. You get the idea. These are all just life questions. We could get more specific. What about the discriminations that you have to make in therapy? So, differential diagnosis. Is this dementia? Is it depression in this elderly patient? How do we distinguish so that we don't over-medicate this person or under-medicate this person if they're in a facilitated living condition? Is this the better therapy approach or is that one better? You come to a conference like this one where you get exposed to how many different perspectives. Should you abandon what you've been doing in favor of starting to do this? Should you stay with what you're doing and forget what you just heard? How are you going to respond to that? What about the research data? People who decide, well, yeah, I understand that there were 62 studies that said that, but I don't believe it. Well, how do you decide whether these data inform you properly or not? Can I effectively treat this person or should I refer them? What about recommendations for medication? All the decisions you have to make in therapy. Even more specific, what about the discriminations you have to make about hypnosis? How do you know when to introduce the hypnosis into the therapy? Is it for everybody, everywhere, all the time? Or do you distinguish, here's somebody for whom it would be a really useful thing, and here's somebody who would probably benefit from something a little different than that? Whether to use a direct or indirect approach, whether to be authoritarian or permissive in your style. Decisions that you have to make. It can't just be, here's what I do, and then here's the one-size-fits-all that goes along for everybody. Okay, so I wrote a book a number of years ago called The Discriminating Therapist. It's on Amazon, it's on my website. It's an ebook, so it's something you can easily download. But in this book, I offered my perspective about the scores, literally scores of decisions that somebody has to make in the course of a lifetime that are going to determine whether their quality of life is a good one or whether they're going to be struggling. You've got to notice, there are some people who move through life and things are so smooth, and then there's other people that are constantly up and down and up and down and up and down. It tells you something. You know, sometimes things happen. The problems you face aren't your fault. You're sitting at a red light, somebody rear ends you. You know, that's not your fault. Although there are some people who would say it's karma. Energy of the universe. No, somebody was careless and they plowed into you. But the point being that you're going to make decisions that are going to enhance the quality of your life, there have to be a number of different decision-making strategies. There are different ways of deciding depending on what you're deciding. It's a different strategy to decide who to marry than it is to decide what you're going to have for lunch. But if you use the same strategy, you're going to end up with problems someplace. So 80 some different discriminations that I describe, and then I take the ones that are the most common in therapy, and I lay out, if I was answering this, here's how I would answer it. That these would be the criteria that I would want to share with my client, that when you're in this situation and you need to make a decision, here are the guidelines to follow. And even if they don't intuitively feel right, that isn't the issue. Does it have to feel right in order to be right? It's one of the toughest issues about therapy. It's a distinction I make between therapies that make you feel better versus therapies that make you better. There's a distinction to be made between feeling better and being better. As I alluded to earlier, there are a lot of things that'll make people feel better. Placebos make people feel better. It doesn't make them better problem solvers. It doesn't teach them better coping skills. It doesn't change their history. It doesn't build them a support network. We need to provide people with that quality of understanding about what they're doing. So, as you saw in my video clip, it all started with that whole session revolved around that first minute of asking how she goes about deciding whether someone's trustworthy or not. So when you're asking the how question, how did you decide this? How do you know whether that's true? How do you determine whether that's the best response in this situation? How do you evaluate whether this is a reasonable or unreasonable risk or reasonable or unreasonable perspective? So by asking that how question, that's when we get a chance to find out what is this person's strategy. Well, as you saw with, her name is Astrid, as you saw with Astrid, her strategy is a non-strategy. She's using the most general criteria that if they're related to me and I know them, then I should trust them. What would you say to her to help correct that? Well, the number one, as far as I can tell, the number one discrimination issue that I encounter time and time again, and I bet you do too, is the issue of controllability. Your clients come in, they're frustrated, they've attempted to change things, they have failed, they're on the verge of giving up, maybe they've already given up, but that sense of futility, that sense of hopelessness and helplessness. So when somebody comes in and they start telling me about hopeless, 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 helpless, 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 and if I come back at them and I say, well, you know, actually there is something you could do here to help yourself, some clients will say, tell me. Other clients will get mad. You're not listening. I told you there's nothing else I can do. Okay, let's work with this for a second. I see some potential for control in a situation that you don't. How do you assess what is within your grasp, what is within your power, and what isn't? Now that's a direct question, and predictably the answer is going to be, well, I don't really know. Well, what this slide's about is the continuum of controllability. At one end of the continuum, you have the illusion of helplessness, as it's known in the clinical literature. At the other end of the continuum, you have the illusion of control. The illusion of helplessness, there's nothing I can do, I'm stuck here. The illusion of control, if I just approach everything in the right way, then I'll be able to do it. And either extreme can land you easily into depression when you discover it doesn't work that way, that it isn't realistic. And I think the best evidence for that, do you remember the little engine that could? Remember that children's story? A little under the hood, I think I can, I think I can, I think I can. You ever wonder what happened to him? Years later, standing on a corner. I thought I could, I thought I could, I thought I could. If you don't accurately perceive what's controllable, you as a therapist can lead somebody to believe that there's nothing they can do if you take that position. Or conversely, you can lead the person to believe that if they just approach it the right way, they'll be able to do it. This is a very difficult issue. Now, normally, when I'm doing a workshop on depression, I'll do an exercise that I'll just describe to you. You'll get the gist of it. I will present to this sophisticated group of clinicians a series of vignettes. Here's the story. So for example, the first one I might use is, okay, here's John. John had a very high-paying job. He was making a lot of money, and typical of his generation, he was spending it as quickly as he made it. Fancy cars, big home, fancy trips, kids in private school, spending the money as quickly as he made it. And then he lost his job. So now creditors are coming after him. They want to get paid. He doesn't have any money. He's terrified. He's going to lose his house, lose his cars. He's going to have to pull his kids out of school to put them in a public school. He comes in and he is depressed. Okay? He comes back a week later and he says, wow, man, you must be my lucky charm, because right after I saw you, I did what I always do. I went through the internet looking for jobs, and lo and behold, there was a job there, and it was new posting, and it's a company that's just a couple of miles away from where I live. They want somebody with my background, my degree, my experience. I called them up and I said, I want that job. They said, okay, great, come on in for an interview on Monday. He says to me, so I can feel it in my bones. The drought is over. This job is mine. Now I will ask my audience, all right, from 0, meaning no control at all, to 100, meaning total control, how much control in your judgment do you think John has over whether he gets the job on Monday?
0.
And every time without exception, I get the full spectrum. You get people who say 0, you get people who say 100, and everywhere in between. Now, what does that tell you? What it should tell you is, I got a room full of therapists who don't have a reliable strategy for determining what's controllable. We know it's not 0. There are things he can do. He can update his resume. He can stand outside and watch people come out and see if they're in 3-piece suits or blue jeans. He can read the mission statement and learn the language. He can update his resume. He can prepare answers for the questions he's likely to be asked. There are some things that he can do. It's not 100. He's not the one who makes the decisions. He can walk in for the interview. The interviewer takes one look at him and says, "Ooh, reminds me of my cousin Billy Ray Bob. I hate Billy Ray Bob." It's not up to him. It's not 0, it's not 100, but if I'm that client, if I say to John, John, you're not in control of whether you get that job. There are things that you can do, things that you should do to create the possibility. And that's the language of hypnosis, create the possibility. Can't guarantee it, shouldn't guarantee it, but you can't guarantee it. And that's the thing, is when we start talking about creating possibilities, why it's so valuable to couch suggestions in permissive terms about what the person might experience, what they can discover, what they may experience. And isn't it contradictory, isn't it incongruent that if you want to empower people, which is a constant goal of any therapy, if you want to empower people, the more you tell them what to do, the more you're demanding compliance. How do you empower people? By demanding them to be compliant. It doesn't even make sense. So that process of assessing controllability, like in that sample from the exercise that I do, if John then asks me, well, then how do I determine whether it's in my control or not? Again, I'd love to hear your answer at that moment. Because again, if you can't explain it, if you can't articulate, here's how to determine whether it's controllable or not, how's he supposed to learn? How's he supposed to develop a strategy for being able to approach similar situations in the future? Well, if you're going to teach discriminations in hypnosis, and I certainly hope I'm motivating you to want to do that, that you recognize there's a sequence for it, there's a process. First of all, you want to identify the contexts in which the client's view may in fact be valid. There are times when John, thinking that he's going to be in control, he's going to be right. He is going to be in control. But there are times when he isn't. So I'm not negating this person's desire to be in control or the value of them being in control. On the contrary, I'm basically saying it's good. You want to be in control, you should want to be in control, but you need to learn. In this context, you can. In this context, you can't. You can't make your kid care about opera. You can't make fill in the blank. You can't make someone go into hypnosis. You can't order someone to relax. It's not about imposing. It's about eliciting. You want to know the distinction between styles of hypnosis? It's right there. The difference between imposing on someone versus eliciting from within someone. All right, so then we can start to talk about the exceptions, the counterexamples. When doesn't that pattern work? When doesn't that pattern apply? Then we can provide the criteria, articulate, here's how you know, here's when it's okay, here's when it's not, here's when you should, here's when you shouldn't, all those kinds of criteria that we introduce hypnotically. And of course, this is one of the great things about hypnosis. There are many great things, but one of the things that's so intriguing is the phenomenon called automaticity. Automaticity is how this person integrates this concept, integrates the idea, integrates the perspective that ripples through them so that it can be available even in situations you haven't talked about. Now that is valuable, and it is the heart of process-oriented hypnosis. This book came out in 2021, the Society for Clinical and Experimental Hypnosis called it the best book of the year. Well, all right, people's problems are unique, or are they? If you've been doing therapy for any length of time, you discover how redundant therapy is. It's the same problems over and over and over again. Different names, different faces. The content will differ, but not necessarily the process. So what I'm interested in then are the sequences. The sequences. How does this person generate their anxiety? How does this person generate their level of depression? That's a very different question than why. As soon as you ask why, you're inviting speculations, you're inviting theorizing, you're inviting projections. I'm interested in finding out exactly what is this person doing in that moment. How do they make that decision? How do they implement that particular behavior? So at the process level, if you don't get caught up in the content, then it doesn't matter how old they are or how many academic degrees they have or where they go on their vacations or any of that. It's strictly about here are the steps they follow that land them where they really don't want to be. So for example, content versus process in therapy. If you're going to deal with a phobia, okay, you deal with that particular phobia. So do we change the person's or strive to change the person's response to flying or whatever the phobia is about? Or do we strive to change the way that they deal with things that they're afraid of? Especially when we know that people rarely have only one phobia. People typically have multiple phobias. Or at the content level, what's the specific thing that they're so angry about? At the process level, how do we change the way they deal with frustrations? addressing a specific impulsive behavior, drinking too much, taking drugs, casual sex? Or are we going to change how the person deals with their impulses when they come up? So anyway, you get the idea. We're not getting lost in the content of it. That's what takes so long in therapy. Somebody walks and sits down, especially when they're presenting depression, and they start telling me victim stories. You know, my spouse does this to me, and my kid does this to me, and my boss does this to me, and I'm like, okay, got it. People keep doing things to you that you don't want them to do. Okay, now you want to talk about what to do about that. That whole interaction takes 5 minutes. Now, there are times when people want to tell me the whole story, and I'm willing to listen to it. But if you want to know the difference between short-term treatment and long-term treatment, it's right there. How much content do you get involved in? Well, the new edition, 6th edition of Transwork just came out a few months ago. And the 5th edition had come out in 2019 before COVID, which changed everything in terms of how we deliver therapy. So it's pretty valuable to have a more current version of what's really going on. It deals with AI and it deals with telehealth, doing therapy over the internet. Now, let me switch gears altogether and share with you something that has great meaning to me that came out of nowhere. I've been talking to you about sequences and the patterns that people have and the steps that they follow to get where they're going. Well, one day out of nowhere, I get a phone call. Many of you have probably heard of the famous, world famous San Diego Zoo. It's really at the top of the zoological world. How many of you have actually been there? Some of you have. Great. So there's the San Diego Zoo, and then there's its sister park called the Wild Animal Park. Now it's changed its name recently to the Safari Park. But one day I get a phone call out of nowhere. He says, "Hi, my name is Jim, and I'm calling from the Wild Animal Park. Are you familiar with the Wild Animal Park?" I said, "Yeah, I'm a member and I'm out there all the time." He says, "Good. Okay, so here's what's going on. Elephants are highly endangered. Elephants could become extinct in as little as 20 years. They're being poached in the wild for their ivory. They're being killed because they intrude upon villages, and villagers will shoot them as unwanted trespassers. And it's very, very important that we are able to breed elephants in captivity in order to be able to develop the patterns and learn how to reintroduce them into the wild and hopefully save this magnificent species from extinction. Because as elephants go, 90 other species that are dependent on elephants will also go. So it's critically important. San Diego is one of only 3 places in North America that can breed elephants. Keeping male elephants, bull elephants around is a very dangerous business. Male elephants go through a period called must, spelled M-U-S-T-H. Every 12 to 14 months, the testosterone is flowing heavily. They get very aggressive. Most parks can't handle them. We can. So it's very important. I'm listening to all this, and finally I interrupt him and say, "I'm a clinical psychologist. You know, why are you telling me all this?" He says, "Hold on, I'll get to it." So he goes on saying how dangerous it is to breed elephants and how important it is to the conservation world to develop safe and effective management strategies. And then he says, "Okay, so now let me get to here's why I'm calling. We currently have 23 elephants. We want to establish a breeding herd of 120 elephants. And in order to accommodate a herd that large, we're going to need to hire many more trainers, many more keepers, and we don't want anybody getting injured or killed. The problem is, the guy who's in charge of the program, his name is Alan. Alan is a wizard with the elephants. He is an amazingly skilled elephant trainer and handler. The problem is when you ask Alan, how do you do what you do? He very insightfully says, I don't know, I just do it. So now, Dr. Yapko, will you come out to the park, study Alan, figure out how Alan does elephants, and develop the training protocols for all the new trainers and keepers that we're gonna need to hire. And instantly, my mind is swimming with, are you kidding me? Come out to the wild animal park, study elephant-human interaction, expose myself to the dangers that they're talking about? How can I do that? And then in a fraction of a second, the next thought was, how can I not do that? So I said, okay, I need to meet with Alan. I need to explain to him what I'm gonna do. I'm gonna need to be everywhere he is, doing everything he does. I'm gonna need to ask him 10,000 questions a day, to which he's most likely gonna say, I don't know, and I really don't want him to punch me in the face. So I need to meet with him and explain what my whole process is gonna be. So to make a long story short, I spent 3 years with elephants. And the project was exceedingly successful, so successful, in fact, that I started getting invitations from other zoos, including the London Zoo. Will you come do for us what you did for San Diego? So there I am with 2 of my friends. And of course, elephants are an exceptionally complex creature. Very strong family bonds, very strong socialization process. Gestation is 22 months. When a baby elephant's born, it typically weighs about 100 kilos. Mom's real glad to see him go. And so the goal, of course, is breeding. And so we were blessed with a little guy named Omar who was born. Omar was rejected at birth by his mother. I became his surrogate mother. And, baby elephants have no idea how strong they are. But you get a chance to see how fuzzy he is, and just really amazing. We published on our work, and I'm really proud of the fact that so many zoos around the world picked up on what we did. And the essence of what we did was this. I look at this picture and I realize I am really dumb sometimes. Because this is exactly where the danger is. That you're in what's called a hands-on program. You're in with the elephants. Again, the goal is breeding. So you're taking blood samples and urine samples and stool samples, and you're constantly handling the elephants. And all it takes is a half step, either one of them, and I'm dead. And that something flashed. I'd been there probably 6 months already, maybe even longer, when it dawned on me, that's the problem. So I said to the park management, what we need to do is change the style from hands-on to hands-off. And they said, well, we've never done that before. I said, that's what makes sense to me from everything I've learned. Let's build permeable barriers. Barriers that the elephants can actually stick a leg through or stick their trunk through, but the keeper's on the safe side of the barrier. And we train the elephants to respond to verbal signals. Step forward, step back, side, trunk up, trunk down, leg through the barrier. So I spent the next year training elephants to respond to more than 40 verbal signals. If you ever need your elephant trained, I'm your guy. So it was a very successful project, and I'm particularly proud of the fact that I made this contribution to the conservation world. And I continue to. It's, to me, a very important thing. Obviously I care about people. I've dedicated my entire life to helping people. But elephants are on the verge of extinction. And how important it is to be able to play a larger role in the world that we live in. And it's these very hypnosis skills that I've been talking to you about. Sequencing, process-oriented, discriminations, that I brought to this project that has made a very large difference, not just in San Diego, but in zoos around the world that have adopted the same hands-off protocols that I developed. So it's, by way of summary, an invitation in this presentation for you to consider how you choose your therapy focal points. To ask yourself how much of your therapy approach is based on projection of what you think is important or what you think is the right model to approach people. How much of that involves interpretation, because that's where the danger is. Whose interpretation is better than whose? And what I'm advocating for is minimizing making interpretations. Because as I say, that's where the danger is. You know, I 30 years ago wrote a book called Suggestions of Abuse about false memories that are introduced in the context of psychotherapy. The mistakes that therapists were making, leading people to believe things happened to them that never actually happened to them. And the thing that was so important in the follow-up to that was asking people to send stories about if they felt they had been harmed by therapy. This is a phenomenon called iatrogenesis in the literature. Iatrogenesis, how therapy can make people worse rather than better. And when people started flooding the mail with stories, the common denominator was that the therapist made an interpretation that the client just didn't buy into. And it became a clash. So there's a reason why I'm taking that position. So the focus on the past or future, obviously I'm talking about what can I teach them today that will make a difference tomorrow. Should we focus on only one client at a time? Why I've been so involved in developing hypnosis apps for people. One that in particular is called Claria, which I don't really have time to talk about, but you can go to my website, yapko.com, and you can read about it. Claria is 12 different hypnosis sessions, each targeting a different aspect of anxiety and depression to promote better mental health. And it happens to be free for healthcare professionals with the transparent goal of, if you like it, then you would end up recommending it to your clients. So there's a lot that we're involved in here. I love, as in closing, this saying. When I was in Zimbabwe, one of the tribal elders had this saying: if you can walk, you can dance. If you can talk, you can sing. We are all capable of more. Thanks for your attention, everybody. Thank you.
Michael Yapko, everybody.
Thanks so much.
Simply because where we are at with time, we can take a couple of questions, and then if you want to have photos or ask Michael some more things, you can harangue him in the corridors while we get ready for our next presenters. Does anybody have anything pressing they wished to ask? Yes, please.
I just had a question. I think at the beginning you mentioned about secondary gains.
Yeah.
Behaviors that have secondary gains.
Uh-huh.
Can you just elaborate on your thoughts about that?
The question is about secondary gains. Secondary gains are often taught as a given in clinical trainings, that anytime somebody presents a problem, there's got to be some reason why that supports maintaining the problem, that the person benefits in some way. Therapists who will literally say, well, you must enjoy your depression. Nobody enjoys their depression. Are there consequences? Does the person get out of work? Yeah. Does the person get out of household chores? Yeah. Is that why they're doing it? No. They're the ones suffering the most. So my point is, instead of automatically assuming there's a secondary gain, that it becomes something to question, something to discriminate. Is there such a thing as a secondary gain? There are contexts, again, discriminations. Does it exist? Yeah. When? As an example, somebody gets in a car accident. They're injured. They're not going to go to trial for the car accident for 6 months. If they get out of pain today, they're going to lose $80,000 in the settlement, and they know it. So there's an example of where secondary gains are a real thing. But my larger point is, it shouldn't be automatically assumed. Maybe, maybe not. Again, it requires therapists to be able to discriminate. Okay, let's end it there.
Great. Thank you very much indeed, Michael Yapko, everybody.
Thanks, everybody. Thank you.
But let me just show how many. How to stop it? I don't know.
Are you staying on the next one?
How to stop it? I don't know how to stop it.
Sorry, what you trying to do? Stop the video.
Yeah. Just stop it. I did it live.